Hi everyone, my name is Erica Lee. I'm an undergraduate student at McMaster University, which is in Hamilton, Canada. I'm also a research assistant at the Center for Compassionate Care, which is a ketamine-assisted psychotherapy clinic that's pretty close to my school. And so the topic of my presentation was in large part inspired by my work at the ketamine clinic, and I'm just combining these ideas from a curricular research project and lots of informal discussions with other psychedelic enthusiasts. So this research that gets into theorizing about how psychedelics works is most interesting to me, and I believe that these ideas are going to form from discussions across different parts of the psychedelic community, leading to the most interesting research topics. So I'm going to be talking about current treatments for substance use disorders, also how ketamine is currently used and the importance of its dissociative effects for substance use disorders, and I'll be using psychological theories such as REBUS and CUE-EXTINCTION. Lastly, I'll be talking about how these ideas might inform integration techniques, which are important to ultimately supporting long-lasting progress towards recovery. So in the 21st century, we saw a shift in our understanding of addiction, and we framed it more as a medical issue than a moral issue. And this led to the development of many pharmaceutical solutions, and these usually act as substitutes that target a certain class of drugs. So, for example, buprenorphine for opioids or prescription benzodiazepines and stimulants. It's important to note that these interventions are not often paired with adequate psychological, social, or economic support. Some numbers about substance use disorders in Canada, it's estimated that 21% of the adult population, or about 6 million people, will meet the criteria for substance use disorders at one point in their lifetime. So out of all that require treatment, it's estimated that about 1 in 6 are the ones who receive treatment for substance use disorders. This is a global statistic. So other treatment options, they include inpatient treatments, outpatient counseling, such as 12-step programs, and AA. So AA and NA. So psychological interventions, they target behavioral and cognitive change, whereas drug substitution therapies that I was talking about earlier targets physiological change. So it's clear that all these options exist, but few of them excel at addressing the complexity of substance use disorders from multiple perspectives. So I propose that the dissociative effects of ketamine can be important for creating lasting shifts in the salience of drug-taking cues, which will ultimately support long-lasting progress towards recovery. So ketamine is this reliable consciousness shifter, and it's currently legal, which makes it a very popular choice in psychedelic research. It's currently most widely used for treating depression and has shown to be effective for substance use disorders. It's been tested in clinical trials for alcohol, cocaine, and opioid use disorders. And clinical trials have found that ketamine for substance use disorders is effective for about 2 years. So you can see in this graph, this is the percent of subjects in a study that were abstinent from heroin from up to 2 years after a low dose versus a high dose treatment of ketamine. We can also look at ketamine's efficacy towards concurrent disorders, which are often the underlying cause of substance use disorders. So substance use disorders may act as a coping mechanisms for different comorbidities, where drug use is often a form of self-medication. People who have a mental illness are about twice as likely to have a substance use disorder compared to the general population. So there's a strong correlation there. Ketamine is most well studied for the treatment of depression, and its specific efficacy towards depression and other concurrent disorders can treat these possible underlying causes of addiction. So currently, a set and setting design is not as important as in ketamine treatments as compared to other psychedelic treatments. So some clinics will perform ketamine infusions with limited preparation and integration post-session, whereas with treatments of psilocybin, MDMA, or LSD, there's much more of an emphasis of a strictly designed setting and integration, along with more time with the client to prepare and integrate the experience. So one of the big issues with ketamine treatment is, as we've seen in the treatment of depression, one of the big issues is how there's a lack of lasting change. And so one of the big reasons why that might be is because there's less emphasis on proper integration of the experience. So one possible solution, a review by Zach Walsh and Michelle Thiessen, they propose that an especially complementary frame for psychedelic assisted psychotherapy is third wave CBT techniques. So third wave CBT emphasizes mindfulness-based practices like meditation, addresses cognitive expectancy challenges, targets behavioral change, and wellness strategies. There are some aspects of third wave CBT, such as mindfulness and cognitive expectancy, that bear a very close similarity to psychedelic experience and can support integration of the experience into daily life. So I'll be revisiting later how integration can be better supported by how ketamine treats substance use disorders. So there are various models for administering ketamine, and these three groups and dosage ranges are taken from Dr. Raquel Bennett. So there's low dose, which is with limited counseling and integration, and it's usually seen that ketamine is the medical solution to an issue. So it's ketamine itself that's responsible for the healing. So psychoactivity, such as mystical experience or dissociation, is seen as a side effect. And this is usually on the lower dose, but in some clinics, there can be higher doses given in the same fashion with limited, unfortunately, with limited counseling and integration. There's also psycholytic doses, which do also involve integration after the session. And there's, importantly, talk therapy during the session. So this is a medium sort of dose, enough to experience those subjective effects of ketamine, but not enough to stop someone from participating in a discussion with their therapist. And lastly, there's psychedelic doses, which are typically the highest doses given in therapy. So this involves integration after a session, and the dissociation and mystical experience is strongest at these doses and is most valued at these in these psychedelic treatments. So there are questions about whether the psychoactive effects of ketamine are side effects or whether they are part of the mechanism of action of ketamine. Some research, they characterize them as side effects that should be eliminated or avoided during treatment. However, their attitudes around this are changing very quickly. And so more recent papers support further research into dissociative effects and the effects of and the relationship to the therapeutic effect of ketamine. So looking at the importance of dissociation at higher doses when using ketamine as an antidepressant. So you can see in these papers, these are some earlier papers, the first two, just looking at ketamine side effects as dissociation. And the third paper here is a more recent one that presents a more neutral view of the dissociative effects of ketamine, how it might be beneficial to treating depression. So dissociation can be explained as this state of detachment from the external and internal worlds. And this is characterized by emotional, physical detachment. And this can be caused by ketamine and other NMDA antagonists. It can be caused by trauma, anxiety, or it can be brought on by breathwork practices. So the clinician-administered dissociative state scale is used to measure the intensity of this state. So as you can see in this graph, this is a placebo versus a ketamine infusion, and the scores on the CADSS peak at around 40 minutes. So the famous Relaxed Beliefs Under Psychedelics, or REBUS paper by Dr. Cart, Harris, and Friston, focuses on classical psychedelics, and dissociatives like ketamine aren't focused on fully. So REBUS proposes that the entropic or disordered brain activity that's induced by psychedelics relaxes our beliefs about the world and ourselves. And there's this gradient of serotonin 2A receptors from the subcortical to the cortical region that facilitates this relaxation. And the REBUS paper theorizes that ketamine might not apply to REBUS because it doesn't act in the same way as classical psychedelics, acting on the NMDA and not the serotonin 2A receptors. So it lacks this gradient of receptors in this region of the brain, and therefore these bottom-up influences aren't passed up as strongly. So there's an alternate paper by Dr. Adam Safran called ALBUS, or Altered Beliefs Under Psychedelics, which introduces a broader model under which REBUS is a subset. And it proposes that REBUS actually applies very closely to ketamine, and that other might be better with ALBUS framework for those states of consciousness. Argues this through the in-brain network they found. And so conceptually, the general idea of relaxing priors to facilitate new patterns in rebus can explain ketamine experiences. So here's a study using dextromethorphan compared to placebo. And you can see that there's an increase in network flexibility that's significant compared to the placebo. So REBUS can explain why ketamine and other psychedelics are being used to target substance use disorders. Using the learning model of addiction, substance use disorders are partially formed from the classical conditioning of stimuli associated with drug taking. And so in this case, a bias is developed towards a certain addictive pattern, which is an example of a prior in REBUS. So these high-level priors are relaxed under the influence of psychedelics. And because these priors have been relaxed, the built-up cue craving relationships from the learning model of addiction are diminished. And so they become less salient under the use of psychedelics, which can support abstinence or reduce drug use. So a study by Dr. Elias Dakwar using visual cue exposure while under the influence of ketamine for treating patients with cocaine use disorder found a significant decrease in cue-induced craving and an improvement in motivation to quit cocaine. So here is a scale that indicates the readiness to change, or it can also be looked at as motivation to quit. And this was increased under ketamine as compared to an active placebo. And then over here is cue-induced craving. So this is a measure of that. So this is an active placebo, and this is under the influence of ketamine. As you can see, it's greatly reduced. And so this is currently the only study that focuses specifically on this topic, but they have definitely called for more exploration into cue extinction, specifically with ketamine and other psychedelics with treating substance use disorders. So in summary, ketamine is seen to move someone outside of a ruminative state, which includes both drug craving patterns of thinking and depressive rumination. So some of the underlying causes may be caused by rumination, such as depression and other concurrent disorders. And cue extinction, theorized to be due to cue extinction, which is a form of moving out of addictive pattern or rumination. So overall, ketamine can treat these underlying and immediate causes of disorders. So we can look back at integration and how important it is and how it might be informed our theories of REBUS extinction. So cue extinction therapies could be involved in integration and act as a direct target to substance use disorders. This can be combined therapy integration techniques such as wave CBT. And of course, the relationship between the practitioner and the client groups together, such as neuroscientists, psychologists, and all practitioners, are definitely needed so that an evidence-based and holistic approach to integration can be achieved. So most importantly, it's interdisciplinarity and communication between different groups to help get these ideas across and to further the field of ketamine-assisted psychotherapy. So I hope you can see from this presentation that ketamine for treating substance use disorders has great potential, but research to discern how it can be applied is definitely needed in multiple areas. So first, in clinical trials, to gather more data about ketamine, specifically for substance use disorders, larger controlled trials are required. A better understanding of doses and routes of administration are definitely required to understand the relationship between the subjective effects of ketamine and dose and routes of administration. As well, we are looking at research and developing explanatory models for the treatment of addiction with psychedelics and ketamine specifically. And these theoretical models can inform integration and develop more modalities for the integration of ketamine experiences, which is an aspect of psychedelic-assisted psychotherapy that may be neglected right now. So thank you so much for listening to my presentation. If you have any questions, please ask me during the Q&A period. And I just wanted to add that we're recruiting people for interviews that will be part of a study that looks at the difference between high doses and low doses of ketamine and what they might be useful for. So if you're interested in participating in this study, if you've tried high and low doses of ketamine, then please email me at my email here on the slide, and I'll get you in touch. Yeah, thank you so much.